So some disclosures. I'm not an expert on computers. In fact, my chairpersons, in fact, the third chairperson who is missing, all three of them are much more computer savvy than I am. And we do subscribe to a hospital information system, iSoft. You will see some slides, but there are many other vendors in the market. And if time permits, I'm going to show some video clips, and I've taken permission from Dr. Vespa and Dr. Mani for that. I'm going to use, there are a lot of words used for computers in ICU, and in my talk, when I say computers, it could be one or any of these terms. But hospital information system is the one which is most commonly used. Now, the computers in ICU could be good, bad, and the ugly part of computers in ICU. So let us see how do we go about it. As John Louis mentioned in his session yesterday, is the patient safety. First, do no harm. And I think that is the Hippocratic oath that we have taken when we entered medicine. And the entire medical world, and probably the lay people also woke up about a decade back when this was published, that about 45 to 98,000 people are dying of some kind of medical errors every year in the United States. Is almost like a plane crashing with load of passengers every day. And it has been found that a lot of these are due to medication errors, and which increases costs, and above all, it loses trust in the healthcare system by the patients and their families. And medication errors, both of commission, that we are writing something which we should not be writing, and omission, that we are not doing something that we should be doing, both are responsible for these kind of errors. There are not many studies done in India, but there are few studies gradually coming up on prescription errors even in India. And I think the numbers are probably the same or even more. When I look at my charts in my ICUs, I can't even read my handwriting. Physicians are very infamous for their handwritings. And, it's all over the place. And I think it's a global phenomenon. And there is no doubt this kind of a system where you can go ahead and click onto your patient and get a chart where you can write legibly the name of the medicine, and there are allergies, there are beyond dose limits, there are duplicate sounding names of the drugs which will come up, and it makes life much more easier for the nurses and definitely much more safer for the patient. And the drug allergies, the decision support systems come up. And there are more and more decision support systems with different medications, where as soon as you click on a medication, you can get a monograph of that medications, the different side effects. And in fact, in India, we are not behind. We have this SIMS and MIMS. These are database of drugs which are specific for India. They can be linked with any of these hospital information system. So it is available in our country. If a vendor gets an hospital information system, we can link to this drug database. Now, over years, there has been a tremendous interest in this, and the literature has been exponentially growing. Now, over the last 3 years, as you can see, it has grown almost 200%. And by this article from Dr. Gowande, who emphasized on this computerized physician order entry system, and it definitely decreases the number of prescription errors. There are more and more studies, similar studies are coming up, where definitely preventable errors are decreased by computerized information system. In a Medline database, most of the studies had a positive effect when you search the different studies looking at prescription errors and use of computers. In a computer-based unit versus paper-based unit, definitely the errors are much less in the computer-based unit than in the paper-based units. Now, based on these studies, the Leapfrog group, which is the advocacy group for the industry and for the insurance company, has made a computer physician order entry system one of the mandatory requirements in the US hospitals. And I think it is very important that we have to take a clue from this, and we have to organize this into our system. So that is one aspect of computers which is beyond doubt, I think is very important in the intensive care unit setting. The second is this data retrieval and trending. We have huge amount of data in ICU every day. If I have a 20-bedded ICU, I have 20 times the data on these patients. It's very difficult to keep these data on the chart. If they are systematically put onto the computers, they can be viewed every day and they can be analyzed and they can be trended as well, whether it be lab data, whether they can be vital signs, and one can trend these data and look at the different ways they go up and down. Not only that, like we can highlight the alarms. For example, if there is a hypotension or if there is a tachycardia, there might be a data will start flashing that this patient has tachycardia or hypotension, and even a doctor can get a SMS message in his phone that this lab results of that patient has got serious hyperkalemia, and probably also some information regarding the treatment of this. So I think the information technology is there now for us to utilize, and having this PACS database, PACS software in the hospital information system to get access to the different X-rays and the other CT scanners is also very important. So that is the second part. I think the data retrieval is also very, very important. And this is, I think, very important for our country. Infection surveillance and antibiotic stewardship. As you know, there are guidelines being put down from CDC and other societies about antibiotic stewardship, and they have made the computer surveillance and decision support system as one of the requirements for antibiotic stewardship program. The reason is, if we have a computer assessed management of antibiotics, makes life much easy. You get all the data of the different culture results, you have the different antibiotics, the recommended dose, and what could be the side effects, you get the renal profile of that patient. So makes life easy for the doctors, less amount of errors. And antibiotic practice guidelines through computer assisted decision support is also very important. And they have definitely been found so that the guidelines can be used more at the bedside, and it reduces cost and reduces antibiotic resistance. This is from Belgium, and one of the units in Belgium in Ghent is using this kind of an antibiotic surveillance program, and where they keep data of their daily vital signs. They have the antibiotics and the antibiogram. You can have the SOFA scores, the CRPs, the antibiotics here. You can track the patient's VAP rate, the CRBSI rate, and you can look at their X-rays. You see, if we just imagine, new infiltrates in X-ray is an indication if a patient is not doing well of VAPs, and we keep on retrieving different X-rays, the dates are not there, and if we have a computer with serial X-rays, as you can see, it won't be difficult to diagnose a new infiltrate very easily. So I think at the bedside, it is becoming more and more important to have this kind of technology. It ultimately reflects into a better patient care. We also have the different system in this where we know when the catheters were put in. So a very comprehensive antibiotic infection surveillance system, which will definitely help us in a judicious use of antibiotics. Again, use of computers in communication, use of and handover, having a checklist at the end of the round is also very important. Does it save times for the nurses? Well, there are certain studies which have shown that yes, the documentation is lesser if you use computers than if you use a paper-based system. What about billing? Definitely the billing is much more complete if one has a computer-based system. Procedures are being charged properly, the doctor's fees are being put down properly, and at the end of the day, the billing, if it is linked to the accounts department, is being done much more sophisticated. And I think this is again very important, the quality control and benchmarking through a computer. We have a lot of evidences in medicine and in critical care now. Some of them are very useful, but the problem is, can they be implemented at the bedside? How many of them are being implemented at the bedside? For example, there are data of restricted hemoglobin use. Whatever is the protocol, the data will change, and one can keep on changing the computer decision support system to have the latest evidence incorporated into them. And definitely, if there is an alarm that, look, this patient should not be getting hemoglobin, should not be getting blood transfusion if the hemoglobin is less than 8, if we have put in our algorithm. And I think it is very important, this will give us a warning signal. For example, non-invasive ventilation. In fact, we have been also seeing this. Our SMRs of patients on non-invasive ventilation is pretty high because It could be that it has been used in many off-label indication, you might say, and patients are not being monitored well. So if there is an ICU where non-invasive ventilation is being used and there is high mortality, one can put this kind of a checklist. Any patient on non-invasive ventilation, one has to fill this up, do a blood gas after 2 hours. If patient is not doing well, he needs to be ventilated. Folies removal. Nosocomial infection is one of the biggest problems. We put folies in, but we forget when to take it out. If there is a reminder given to us on a daily basis, how many days the patient had a Foley on the computer, it becomes very important. And we all know about head of the bed elevation. It is very easy for us to say, we should elevate head of the bed. There was a survey done of some of the ICUs in the West where the doctors were asked how many believe that 6 cc per kg tidal volume is ideal. About 100% raised their hands. Then they were asked how many of them were using in their unit. About 80% raised their hands. And when a neutral survey was done in their unit, it was found that only 7 to 10% of the units, when you look in their nursing charts, how many patients 24 hours were on 6 cc per kg, it was found to be abysmally low. So it is very important that this kind of technology are incorporated in our daily practice. So head of the end elevation. If every nursing chart have this, the nurse has to tick it. The nurse has to say this patient was 30 or 45 degree. So the task is complete. So the nurses know that we have to elevate the head end of the bed. So a lot of quality control issues. And it also tells you, giving antibiotics within 1 hour. These are all possible because the data were being archived in computers and the data analysis have shown this kind of results. So these are the good things about having computers in the ICU. Safe prescriptions, good data, ready data retrieval, infection control, data archiving, research, education, quality control, and billing. But we have limitations. We have limitations of this, and probably that is one of the reasons only 5 to 10% of the ICUs, even in the West, have taken this on. This could be the return of investment issues, whether the cost issues and things like that. And there have been studies coming up over the last 4 or 5 years. If we decrease some kind of errors, we might introduce some other kind of errors. It's almost, like a balance. So even these systems, if not judiciously used, can be harmful. There can be more adverse events if the data entry is not being done very correctly. And a lot of things are because the safety alerts are sometimes very annoying. And, the data entry is sometimes wrong. Instead of PTT, you have put an APTT, so the patient gets the wrong antidote. And these are all over the place. So you see, it annoys the doctors. Most alerts are ignored. Alerts often disrupt clinical workflow. So most alerts are not relevant to patient safety. So some kind of upgradation of this hospital information system needs to be done so it becomes more user-friendly. And I think the coming few years are going to go towards that. Yes, all of us are not definitely computer savvy. Now, these are the problems that we think we are also facing here in India in a lot of the hospitals who want to incorporate this information system. Data entry. Data entry is taking a long time. The data display is not very user-friendly. There is a lot of information overload, and there is a lot of double work. Sometimes the nurses have to do the paperwork, plus they have to keep the computers as well. And the interfacing incompatibility. In a hospital which have already got an established lab, radiology, now they want to introduce a new hospital information system. It doesn't fit in with already existing vendors in the other departments, and that becomes a big problem. If you are starting afresh, it becomes easy. If the system is very slow, the entire system goes very slow and there might be breakdown of the system. The cost factor is there, the return of investment is not very apparent initially. A lot of training needs to be done. There are medical legal issues that needs to be sorted out because the Indian courts will still look for paper-based evidence. So it is still very difficult not to have paper-based notes and paper-based charts. And the security and privacy is also very important. And like any other projects, if the project is not done very well, it is doomed to fail. So one has to do at least a lot of homework before one have this hospital information system. And the ugly part of this was this article, which was published in Pediatrics by Dr. Han, increased mortality in pediatrics population in a hospital after computerized order entry system. As you can see, it went up after the computers were put in. The reason was what? From 2.8 it went to 6.6. And the reason, you see, they did not do their homework properly. It's like if cars causing accident, we can't get away with cars. You know, if you have this order had to be put in as soon as a child came with infection. Now they have to go through 10 steps in order to have this order put in. And that slowed the entire system and that delayed the antibiotic use. And that's why the child came to harm. A similar computerized physician order entry system later on in another hospital did not show the same results. The reason was they trained their manpower and they had this order set in before when the hospital information system was put in. So as soon as you don't have to go through all these steps. Customization is very important, and a training period of staff is very, very important. You don't want to ride a half-built flyovers. Now, what is the future? What is the future? Now, I think at the present moment, we are doing all this retrieving from the chart. Now, I think one of the future is if we can get the ventilator data, the monitor data, the infusion data directly from this, which is possible if they are interfaced. All of these have cables which can interface with the computer. If the data come directly to the computer, it will decrease the nursing workload, decrease the error. I hope it works. And this is a robotic ICU. That is the future. We don't have sound here, but you can look. Is there a sound here?
This to you just like this. We're going to get an idea of how this all works.
It's a 2-minute video. It's not coming.
Sergeant Hill, what are settings right now?
So basically, this is a robot which can go around in the ICU. For busy doctors doing rounds in a 30, 40 bedded ICU, it might become almost impossible very soon. So in future, there might be robotic ICUs, at least in the West. So, but we are in India, and where we don't get ambulances in 30 minutes, but we get pizzas in 30 minutes. And so we have a very peculiar situation. It's a great Indian paradox. And I think before we go into the computerized documentation system, we need to get our A and Bs sorted out. We need a good access, early, easy, and affordable healthcare. We need the basic healthcare with human resources, trained human resources, adequate infrastructure. Then only we can go on to computerized documentation system. I think we should look forward, but we should keep our feet on the ground. And I think that is where we should strike the balance. We should always remember, computers are only a tool. Ultimate goal is the quality of care. Computers are not going to outcomes. They are only a tool. They have to be used judiciously, and then only we can quality of care. Thank you for your patient listening.